Today, I'd like to discuss a deceptively bland but high-grade sarcoma, a case that underscores how morphology alone can mislead even experienced pathologists. Our patient is a 15-year-old boy with a history of a sports-related great toe injury 1 year prior. He did not seek medical attention at the time. Over the following months, his pain worsened and was accompanied by swelling, prompting evaluation. An outpatient X-ray revealed a bone fracture with an associated soft tissue mass, and a biopsy was performed. Microscopically, the tumor appeared as a bland spindle cell proliferation set in abundant myxoid stroma. A delicate network of small capillaries was prominent throughout the lesion. At higher magnification, the spindle cells demonstrated fine chromatin and relatively uniform nuclei with only rare mitoses. Some regions contained abundant myxoid stroma with small cystic degeneration. In these areas, tumor cells had oval nuclei and scant eosinophilic cytoplasm. Focally, the tumor became more cellular, as shown in this picture. These tumor cells have small oval nuclei, comparable in size to endothelial cells. These images shown here represent the most atypical areas. In Figure D, the nuclei are hyperchromatic with focally increased mitotic activity. In Figures E and F, multinucleated tumor cells with abundant eosinophilic cytoplasm are present, including cells with a rhabdoid morphology. A small focus of necrosis was also identified, though even within this area, we can still see the characteristic rich vasculature. Based on these morphologic findings, what is your impression? But deceptively bland features made diagnosis challenging. Opinions within our department range widely, from benign lesion to low-grade sarcoma to high-grade sarcoma. Notably, during intraoperative consultation, the frozen section was mistakenly interpreted as a benign giant cell tumor, despite the complete absence of true giant cells. Immunohistochemical studies were inconclusive. Myogenin positive in a few nuclei. Desmin focally positive. MyoD1 non-specific cytoplasmic staining only. No nuclear positivity. Other markers, CD99, S100, SOX10, MU4, EMA, Melin HMB45, CD34, negative. The focal rhabdoid sutures and limited myogenin and desmin expression suggested possible skeletal muscle differentiation. However, the negative MyoD1 ruled out rhabdomyosarcoma. Since both the morphology and immunohistochemical stains are inconclusive, we sent this case for next-generation sequencing. Next-generation sequencing revealed a BCOR-CCNB3 fusion, establishing the diagnosis of BCOR-CCNB3 sarcoma, classified by the WHO as an undifferentiated small round cell sarcoma. The patient subsequently underwent amputation of the great toe, followed by combined chemoradiation. He has remained disease-free at 1 year follow-up. Here we see a picture of the amputated toe. The resection specimen demonstrated a 3 centimeter soft tissue mass with fleshy cut surface invading into adjacent bone. BCORCCNB3 sarcoma is a relatively recently recognized entity, predominantly affecting adolescent males. It occurs slightly more often in bone than in soft tissue, with rare visceral involvement. Its clinical behavior is similar to Ewing sarcoma, including a tendency to metastasize to lung and bone, and it shows comparable response to Ewing sarcoma-based treatment regimens. The morphologic spectrum of BCOR-CCNB3 sarcoma is broad. Some cases are classic small round cell tumors with overtly malignant features. Others are hypocellular spindle cell lesions with bland cytology, making malignancy difficult to appreciate. Some show abundant myxoid stroma with cystic change, And some cases, including the one we just discussed, show focal rhabdoid morphology. Despite this variability, two histologic features are consistently present: a delicate, armorizing capillary vasculature, myxoid stroma, which may be focal but is always present. These features can be critical diagnostic clues, particularly in deceptively bland cases. This is a picture from a WHO book. We see sheets of tumor cells with uniform round nuclei and fine chromatin. This morphology is clearly malignant and fits with the small round cell tumor category. In the background, we see the rich capillary vascular network. In this picture, we see more stroma. The tumor cells have oval, bland nuclei. It is difficult to be certain that it is malignant based on morphology, even more difficult to classify this tumor as small blue cell, undifferentiated rhabdosarcoma. In the background, we see the rich capillary network. Some cases have abundant myxoid stroma with cystic degeneration. Again, we can see the rich capillary vasculature in this picture too. Some cases are deceptively bland and composed of predominantly bland spindle cells. We might even struggle to recognize it as a neoplasm, but not reactive changes. Again, despite this variability, two histologic features are consistently present: a delicate, arborizing capillary vasculature and myxoid stroma, which may be focal but is always present. These features can be critical diagnostic clues, particularly in deceptively bland cases. Immunohistochemistry findings: cyclin D1, BCL2, SATB2, CD99, and CD117 may be positive in a subset of cases, but their sensitivity and specificity are limited. BCOR and CCNB3 immunostains are strongly and diffusely positive in almost all tumors. However, these antibodies are only available in a few laboratories and therefore are of limited practical utility. In addition, both of these two antibodies are not specific to BCOR CCNB3 sarcoma. To wrap up, BCOR CCNB3 sarcoma is an uncommon, diagnostically challenging tumor predominantly affecting young male patients. It may mimic a range of benign and malignant entities, particularly when presenting as a bland spindle cell lesion. Awareness of its characteristic delicate vasculature and myxoid stroma can raise suspicion, but definitive classification often depends on molecular testing. Early recognition is essential, as its behavior parallels Ewing sarcoma, and patients benefit from Ewing sarcoma-based treatment regimens.